So thank you, organizing committee, for this opportunity to speak. And I'm the last batsman of the day, and thanks for the audience for waiting for this. So this is a very interesting topic, LADA, latent autoimmune diabetes in adults. So up 1990s, we had only two sections for diabetes. We had an insulin-dependent diabetes, which we used to call juvenile diabetes, which is now type 1 diabetes. And the second was a non-insulin dependent diabetes, which had lot of insulin but resistance, which we now call type 2 diabetes. And then we realized that all type 2 diabetic patients are not the same. Some of them behave differently. Some are leaner, they require insulin faster, and they are younger. And so the terminology 1.5 diabetes came into existence. Same as latent autoimmune diabetes of adults, same as hybrid diabetes, double diabetes, LADA, young over diabetes of maturity, slowly progressive. So you see there are so many names. They all are the same. Simply, a simple definition to define LADA is diabetes with the phenotypic characteristics of type 2 diabetes, but with the immune markers, usually autoantibodies, characteristic of type 1 diabetes. So now, how can we distinguish when we see a patient in our consulting room, whether it is LADA or whether it is type 2 diabetes? Are there any characteristics? They looked at the age and went back to the UKPDS. In the UKPDS, they estimated the autoantibodies, and they found those who were positive for antibodies were between at the age of 35 and then later at the age of 55. There was a bimodal distribution of age, so there was no fixed age. The BMI also did not give us much information, but definitely the LADA patients were a wee bit leaner than the type 2 diabetic patients who are antibody positive. Acanthosis nigricans is a feature of insulin resistance seen in most of our type 2 patients, but we also see this in some of the LADA patients. Clinical presentation, whether it's an acute ketosis prone or whether it's incidental, slow, also does not give us much information to distinguish between LADA and type 2 diabetes. So neither age, nor obesity, nor clinical presentation helps us to distinguish clinically a LADA patient from type 2 diabetes. So basically, then, LADA is a hybrid form of diabetes with clinical features of both type 1 and type 2 diabetes. Not only that, when you look at the genes, and you see that in the figure, TCF7, which is characteristic of type 2, and HLA-DCB1, which is characteristic of type 1, can be present in LADA, and therefore it's a genetic mix of type 1 and type 2 diabetes. Family history is a strong predictor of the risk of LADA. The Immunology Diabetes Society, which basically is a scientific body for type 1 diabetes, have proposed criteria for the diagnosis of LADA, and the age being 30 years. Most of the studies have estimated GADA antibodies, and there has to be a minimum period of 6 months before insulin is required. The Chinese study, the LADA Chinese study, I think the Chinese are coming up in every way. So they have given a lot of information. As you know, China is a very populous country. There are more than 94 million diabetics in China, out of which 6 million are autoantibody positive. So there is a prevalence of 6.5% LADA patients in China. And when they estimated these antibodies in these LADA patients, they found that these had a bimodal distribution. There were patients with high titer antibodies who behaved differently and resembled type 1 patients, and there were patients who had low antibodies who clinically resembled type 2 patients, and the cutoff point being 180 units per ml. The patients with high titer were younger, they were leaner, they had a very quick decrease in their C-Peptide, and so they were insulin requiring earlier. In contrast to this, those who had a low antibody titer were obese, they were slightly older, they had features of the metabolic syndrome, their C-peptide levels were higher, and they required insulin much later. When we looked at the beta cell function, they found that those patients, as you can see from this graph in the red, those who with high titer LADA were insulin requiring earlier compared to the type 2 diabetic patients, and the ones with the low titer who resembled type 2 patients. And the proportion of patients who reached individuals who had a fasting C-peptide more than 50% were in the ones with the high titer group. And from this graph it is seen that type 2 diabetes, which is purple in color, resemble those patients who had LADA of a low titer group, both in the level of the fasting C-peptide and the postprandial C-peptide. And the proportion of patients with a fasting C-peptide decrease more than 50% were highest in the high titer group. Another study done in Botnia, Finland, also showed a similar pattern. In the graph in the upper half, you can see that they estimated the titer in the relatives of the LADA patients. And these patients who were relatives of the LADA patients became diabetic faster. And those who became diabetic faster had high titers of GAD antibodies. Another big study which is done in Sweden, this is an ongoing study, ESTRID study, epidemiological study to find the risk factors of LADA and type 2 diabetes. It's done in 2 counties of Sweden where they took LADA patients and type 2 patients. LADA patients were identified by an age of onset more than 35. They were GAD antibody positive and their C-peptide was more than 0.3 nanomoles. And type 2 patients, the age of onset was also more than 35, but they were GAD antibody negative and the C-peptide was higher, more than 0.72 nanomoles. They saw this patient with the family history and they found that the family history was positive in both the LADA and type 2 patients. So if you have a first degree relative or a second degree relative, the odds ratio for the development of LADA and type 2 diabetes was high. When they stratified the LADA patients, they found that those who had a relative for type 1 diabetes were at higher risk for the development of LADA compared when the family history of type 2 diabetes was seen. But when the family history was positive for type 2 diabetes, then the incidence of type 2 diabetes increased, opposed, in contrast to LADA, where the family history of type 1 diabetes was increased. And when we look at the parents, there was a similar incidence of LADA in the offspring, whether the father or the mother was type 1 diabetic. So there was no distinction. What about birth weight and diabetes? We know that low birth weight is associated with high risk of type 2 diabetes. And high birth weight is a risk factor for type 1 diabetes. What about birth weight and LADA? This was also a subgroup of the ESTRID trial done in the Karolinska Institute. And this is what they found, that when the birth weight was low, the risk for LADA was high. the risk was for type 2 diabetes was also high, but much more for LADA. When they stratified the age, they found that as the age goes lower down, much below 3 and 2.5, the risk for LADA increases several fold. When they actually the birth weight was taken on verbal questioning, when they saw the birth weight, and 50% of the patients already knew their birth weight luckily. So when they questioned about their birth weight and then saw their current weight and combined the two, they found when the patients had a low birth weight but developed obesity later on, that means their current birth weight was high, the risk for LADA increased. So also the risk for type 2 diabetes. So how do you know that we are seeing a LADA patient? It could be that at the age of 35, we could be seeing a type 1 patient who is presenting at a late age because the autoantibodies are positive, they are leaner like the type 1 patients, they have low C-Peptide like the type 1 patients, and they require insulin. But you see, here is the difference. They not only differ phenotypically, but they also differ genotypically. And these are all the type 1 variants. The HLA-DQ-B1, which is high risk for type 1, and PTNP, which is also high risk for type 1. And if you can see the blue color, LADA patients, and also look at the type 1 diabetic patients who are more than 35, that is the stripe patients, you will see that LADA patients have an intermediate frequency for the type 1 gene variants, HLA-DQ-B1 and PTPN. But for CTLA and for the insulin gene, it was not statistically significant. So LADA patients do have gene variants which resemble type 1 patients. And what about type 2? Two studies, one in Bothnia, Finland, and the other in Sweden, saw about 1,000 LADA patients and at the same time type 1 diabetic patients over the age of 35. And they found that the single nuclear polymorphism, SNPs, which was seen in LADA patient, matched in few of the type 2 diabetic patients, which shows that LADA patients also have variants of type 2 diabetes as well. And when they did the meta-analysis for LADA patients in both these studies, they found that the odds ratio was high for the TCF-L2 gene and for the other genes, which was a mixture of type 1 and type 2. So LADA is actually and really a hybrid of type 1 and type 2 diabetes, both phenotypically and genotypically. So what do we give our patients? We know that insulin is given in most of our patients, although we can treat LADA patients for the first 6 months after the onset of diabetes with OHA. This study was specifically done to try sulfonylureas in comparison with insulin, and you can see that those LADA patients who were put on sulfonylureas deteriorated, or the beta cell failure progressed very fast compared to those who were put on insulin. And the number of patients who are in the sulfonyl group and the deterioration or progression of beta cell failure were higher than in those who were in the insulin group and were more stable. Another OHA of late has been tried, DPP-4 inhibitors. DPP-4 is expressed in the T cells. The T cells are known to produce autoimmunity and produce antibodies. DPP-4 inhibitor sitagliptin has been shown to maintain the fasting C-peptide, the postprandial C-peptide, and the change of C-peptide much better than those patients who are put on insulin. There are not many studies done with DPP-4 inhibitors, but this is just one or two after having searched so much. This was another study where DPP-4 inhibitors given in patients, in LADA patients, were controlled much better despite insulin therapy when they showed in the graph a well-maintained high levels of 1,5-anhydrous glycetol at 3 months, and the HbA1c was reduced much better than patients who were on insulin alone. So in summary, LADA is a hybrid disease, diabetes. Neither obesity or clinical presentations can define LADA phenotypically. High GAD titer LADA resemble type 1 diabetes. Low GAD titer resemble type 2 diabetes. Family history of type 1 and type 2 increase LADA risk. Low birth weight is a risk factor. There is a genetic mix of type 1 and type 2 gene variants. Favor insulin over sulfonylurea treatment. Favor incretin-based therapy over sulfonylurea treatment. And immunomodulators is probably the therapy of the future. Thank you very much.